Welcome to the Capstone Conversation, where you learn about what's happening in the greater East Bay. I am your host, Jared Asch. Today, we are going to talk about mental health. We keep hearing about the mental health crisis that's going on with schools, with adults in the post-COVID world. What does that mean? How can we help people here in the greater East Bay? Today, I am joined by two experts, Dr. Karen Tribble, who is the director of the Alameda County Behavioral Health, and Jesse Tamplen, who is with John Muir. Dr. Tribble, will you start by telling us a little bit more about yourself and your role at the county?
Absolutely. As you mentioned, I oversee the behavioral health department in Alameda County, which includes system and services and partners. We provide county services, obviously, but really rely on our contract organizations, institutions to help provide support to those particularly in need, and those are more vulnerable. In terms of who I am, I have an eclectic background in behavioral health, behavioral medicine, and social work, psychology, so that I am hopefully able to provide some insights globally. So that is who I am. In terms of the crisis, I think that's probably a broader question.
Jesse, can you tell us a little bit more about your background and what John Muir's role is?
Yeah, good morning. It's a pleasure to be on this meeting with Dr. Tribble. I've known her for years. My name is Jesse Tamplen. I'm the Vice President of Behavioral Health at John Muir. I have system responsibilities for behavioral health throughout John Muir. We focus on our emergency rooms, our medical hospitals, and then John Muir also has a 71 bed acute psychiatric hospital for children, adolescents, adults, addiction medicine, and geropsych. We also have our partial hospital intensive outpatient program and some innovative programs for behavioral health integration in primary care. My background is a gerontologist originally as a licensed clinical social worker. And then in gerontology, I really found out there was something called therapeutic nihilism, meaning that the older you got, the more society didn't see you, especially when it was related to substance abuse and mental health. I spent a lot of time working in substance abuse and mental health before I came to John Muir. And my goal in leadership is just what we want to provide evidence-based medicine and practice. We want to have evidence-based management and evidence-based healthcare delivery. That's where one of my passions is, to address any health inequity. If it's in mental health, if it's in cancer, you want to bring the same improvement science to support our patients and elevate their health care.
That's a lot to take in, but I like the approach and how you're really looking at the whole person and how you could take a scientific reasoning behind it. Let's talk about the mental health crisis. We hear this is a news media headline a lot lately, especially post-COVID. What is going on? Why is it being labeled as a crisis? And who's impacted by this? I know those are some broad questions, but I'd love to get your thoughts on Dr. Tribble, if you want to go first, and then Jesse.
Absolutely. And I will add one slight nuance. For us in the field, we use the terms interchangeably, but the way that I think will be helpful to conceptualize it is when you think of mental health diagnoses and depression, anxiety, even schizophrenia, really complex conditions people have, substance use just as prominent. And so when you hear behavioral health, that's inclusive, and the integration with their healthcare partners in hospitals and clinics, a huge monolith that speaks to a lot of different services. Now, to answer your question, why is it a crisis? I think it's helpful first to start in very simplest terms. The resources are exceeding the need. There is a huge number of individuals cross sectors used to, and unfortunately, there's a lot of stigma, obviously, with mental health and substance use, period. And so I think at both federal, national level, even worldwide, I would say, there was a degree of comfort because people began to unfortunately attribute that to them or people who experienced that or family members of those individuals. And what we've seen over the last several years, so many factors, that's probably for another time, but we're seeing growing need beyond those, quote, individuals who have historically been suffering from the long-term chronic conditions. The pandemic just ripped a Band-Aid off the wound of behavioral health because we saw many folks who, and as you mentioned, I really appreciate VP Tamplen's description of holistic approach. I truly believe the biopsychosocial, even spiritual component of being a human being was rocked. Regardless of how you felt on a political level, people were isolated, really couldn't get their social needs met. People's health issues were way beyond their control. There was even a degree of an existential crisis. Who am I if I'm not connected? I can't work. I'm not able to take care of my family. Is this real? Is this political? There was just so much. And after that, what people had hoped for was everything would go back, quote, to normal. And we were not seeing that. We're seeing more people who ordinarily would have thought it was, again, people who were having more chronic disease, having more anxiety, feeling more uncomfortable, feeling more scared, insecure. It doesn't help that there's so much complexity across the nation politically. People's livelihood is impacted. People's ability to just live and be is feeling threatened. It's just enormous. The crisis is because truly the need is really outpacing the ability for many of us to catch up. And it's becoming more acute, meaning people who are presenting for supporting care are much more complex, much more difficult to treat, much more intense than they have been. It is really across the age spectrum, which is, again, who we serve from prenatal to older adult and beyond, and families. We're just seeing things are more difficult. And then the only thing I'll say is it doesn't help when there's a workforce crisis. We don't have as many people going into the field as we need to help support the need. It's just a really complex set of variables. It is really hard right now for many people, and not just people who are impoverished, any walks of life, any political persuasion. So that's how I would describe it.
Jesse?
The stigma for mental health has been around for a very long time. And when we look at what is the impact of that stigma on individuals, we know that when you're diagnosed with a serious mental illness in the United States, you're dying 25 years younger than the average population. If you have substance abuse on board, it's even higher. And they're not dying from their mental health condition. They're dying from physical health. Obesity, cardiovascular disease, diabetes. That stigma has had people unseen or their diagnosis equaled their identity. And I think through COVID, with that understanding of whole person care, and I love that aspect of also adding spirituality, they do it in that biopsychosocial spiritual model. People had that reckoning that we do need to take care of the whole person, regardless of the economics of healthcare. And where we see the economics of healthcare really drive the workforce shortage is when you look at behavioral health payments, the federal government or the states, especially when you compare them to inpatient, they're the most underfunded care in the United States by 33%. So that means treating somebody in an inpatient hospital, a hospital has to that basically subsidize that 33% of unfunded care. Now at John Muir, we're a nonprofit and we're here to support our community. We have child, adolescent, adult, older adult, and addiction medicine. And we partner with Dr. Tribble and help support Alameda County residents as well too. But many people throughout California don't have access to that inpatient life-saving care within 30 to 45 minutes. Many times they're going 7 to 8 hours. My hospital at John Muir is a destination program for LA County and San Diego County because of how few child and adolescent specialized inpatient treatment there are. And we know that, as Dr. Tribble was saying, the earlier that we provide treatment, the more that people recover. And people recover with effective evidence-based treatment. We know this. We're working to remove that stigma, to get people the right treatment. And where we really look at that crisis, because mental health, depression is the biggest disease burden, costs us more money than any other disease in the world. But where we have that crisis is we don't have the trained professionals. We don't have the workforce capacity to be able to do it. And part of it has to go back to the economics, because if mental health is underfunded, it's very hard to recruit the workforce to say, you want to come into a field that's going to be underfunded and you're going to provide services, but it may not cover the cost of care. That's not a very effective business model. but because so much of this is about health equity and elevating our children, our adolescents, and our community, people have a passion not only to go into healthcare, but they have to have more of a radical passion to go into mental health with all of the challenging economics and also the stigma associated with it. I really agree with Dr. Tribble. We're at a crisis because we don't have the providers to treat our patients or our clients. Now, what I can say is over the last 30 years, we made gains in what type of treatment we need to provide. We have the treatment. Now we just need the providers to be able to support those patients in our communities and provide whole person care.
Interesting. We talked a lot about adolescents, teens in here with the mental health crisis. Is it worse in California than in other states that weren't as isolated during COVID? Did it get worse here because so many students, so many people we were out of school longer, as an example, or?
And that's a great question. We're in California. Regardless of what your political lean was, we were incredibly sequestered as compared to other parts of the nation. We typically do have more per capita, quote, organizations and county government and facilities that can help. And we were one of the first states who actually lifted up telehealth and by phone and contacts. Many of us still wore our super suits and went out there, even with COVID, when things shut down. We stayed in our offices or our clinics and we did the work. And that way, California, I think, fared better. However, what's more complex, because you had so many, we're speaking of youth, who were regularly used to having school-based services, having contact with their social workers, with their counselors, their clinicians, to move to a place where you abruptly don't have that was really complicated. What was interesting, we also found in the pandemic, we had a decrease in social service reports. So that meant that families or the community really relied on teachers to help say, hey, the student's not doing as well, or hey, have you dropped in with your counselor? Families already approved and supporting services. I would say that maybe was an abrupt shift, which can be incredibly complicated if you're used to being able to access services, to go from that to zero, to figure out how to then reach my provider, because it took us a minute to do that. That, I think, was really complicated. It's almost if you didn't have it, you didn't know that it was out there. That we did see just a significant drop in kids' desire to acknowledge that I'm doing well. It was really difficult for them. It really was, that isolation. It is a yes and with some context to, I think, how California did. But we did, thankfully, I think, county by county, or in the Bay Area even, really recovered and had to recalibrate. And that just speaks to what I was saying earlier about really focusing more downstream. We have a lot of preventative opportunities, but what we did find is that, again, as Jesse mentioned, the evidence-based, the things that really worked in communities, we actually had to ratchet that up times a kabillion, if I can use that fake mathematic term.
Yeah, and I have 3 daughters, 10 and under, and the oldest one was in kindergarten and didn't get to finish that year when COVID first started. And I noticed the difference in her and the middle one versus the younger one that didn't have the same impact of all the COVID stuff. And they're shy, they're timid in a way. It's, hey, we're at the ice cream store. No, don't tell me what you want for your ice cream. If you want the ice cream, you got to ask the person behind the counter. And it just like little things like in the mental health crisis.
Absolutely. We take for granted what kids learned by being around each other, even if they didn't like each other. They learned how to assert and speak and use their voice. And I think was a curse somewhat, or a blessing. Social media kept them connected, but then social media also kept them isolated. Apparently, we weren't able to see exactly what those impacts were. A lot of folks, little kids got a little fluffier. And we all did, the COVID pounds or whatever else you felt. And that was hard on them. So I don't mean to jump in, but yes and yes, what you're describing is real. It is very real.
Yeah. Jesse, before I dive into the whole social media aspect that we went into there, do you want to add anything else so far?
I think one of the areas that I want to just give a call out is all of the healthcare workers pivoted incredibly in this unprecedented area. Healthcare workers had to ramp up. And I think it's also important to note healthcare workers' well-being, healthcare workers had to pivot through telehealth. Maybe we created some more access in other communities than not. Our healthcare workforce was already strapped and frazzled, and then they even pivoted greatly and really went against the culture because everybody else was shutting down, but healthcare workers needed to lean in and do innovative interventions to meet patients where they're at, clients where they're at in the community. Also, I think people got a huge appreciation for what our teachers do and how important teachers are to the developmental health of our kids. If they have a mental health diagnosis, if they don't have a mental health diagnosis. So I think we're still looking at what is that research. You said for states that closed down schools and states who didn't close down schools, we know that kids need to engage. They need to, as you mentioned about your daughter, don't ask me to order ice cream. Go directly, be direct, stand up for yourself, say what you want. Those are areas that we're looking to overcome and help people move forward. But what Dr. Tribble said, and I think it's critical about the ecosystem that we need to take care of our kids, our schools play essential roles in normal health, but also identifying those signals where there may not be normal health, if it's mental health or physical health, or kids need food, or there may be challenging home situations. Our teachers are on the front line and they're signaling expert systems or getting people into the systems Dr. Tribble and I run to be able to support those kids. And when we need to expect that when those were removed, Dr. Tribble and myself and other people in the field in healthcare tried to do everything we could to make sure that those kids got that care. But you don't see all those kids when they're in school interacting with each other, with their teachers. And those are how we have positive pro-social determinants of health. Many people talk about social determinants of health as a negative, but there's the opposite side. They're also protected. And I think that is something that we missed, and we need to take that acknowledgement of how do we help those kids, especially you noticed it in your daughters. There's probably different critical areas that help. Like my son was in 4th grade, but he wasn't in high school and he wasn't in kindergarten. And for me, I thought he was actually the perfect developmental age to go through COVID because he had the autonomy to use a computer. He could talk to his friends. He's developed those behaviors. And not only do I see clinically with patients we treat at John Muir very early and those graduating high school, people have lost huge experiences in their lives, especially those who are into sports, especially those who are into community, because some of their biggest positive social determinants of health, their protective resiliency factors, were taken away, and they're still trying to figure out what happened because they played on the football team, they played on the baseball team, they played on the wrestling team, they played on volleyball, and that got taken away from them overnight. The one positive thing that I think Dr. Tribble talked about too, about pandemic, is people are much more open to talk about mental health, talk about whole person care, and connecting people to their community and making sure that they have the resources and the support and the treatment they need to succeed. Would we be having it if we didn't have the COVID-19 pandemic? It has become visible and people are reading in, and we're looking at what can we do to continuously improve to support our children and adolescents, and of course, anybody diagnosed with a mental health or substance abuse condition.
Let's build on that. How can the community help? How can the school system help? What should people be aware of to help identify it, to help get people resources?
Sure. I think it'll build a little bit on what the diamonds that Jesse mentioned, probably more so than ever, because as he described, kids having a developmental or a social break in their development, the experiences, the highs, the lows, the joys, even relationships, boyfriend, girlfriend, all that good stuff has changed for them without the resources and the time they needed to really digest it, like we all got to have. I say that to say when now more than any time, I think when parents or schools or teachers hear when a child reaches out or says something that maybe 20 years ago was just a colorful expression, I hate this, or school sucks, I don't ever want to be here anymore. I would encourage people to take it much more seriously than we ever have had to. Not to pathologize a child at all, but to lean into praising and encouraging them to describing those feelings. And then in any way, even if it's a text or a comment or lunch or a burger or hot Cheetos, just have a conversation about what that means. And, what we found, I mentioned it earlier, even though COVID came and really then highlighted and people are now talking about wellness and mental health and it's all those good terms that we've been fighting for and are pleased that people are feeling comfortable with that. There's still a degree of stigma. And so having connections, and that's at least another good thing that was born out of COVID, it could be with the local religious facility or that they have team groups. It could be folks or clubs. It could be if a child, I appreciate computers. I've got a few of those who really love computers and coding and stuff. Is there a coding club? Is there somewhere where they can have access to other people and be able to share and talk through some things? And quite frankly, just giving a call to anyone. What was fascinating is in the middle of all of this, the world didn't stop. Not only did our teams have to come and go to work, and many of us, I'm proud, I'm barely now a year and a half, 2 years into virtual work. I was one of those folks who were still here yodeling down the hallway because we didn't see many of our county colleagues. But at the end of the day, it was something that it really emanated at the federal government. But as opposed to 911, when you start to really see some complex issues, calling 988 is an easy recognizable number to just, even if it's not emergent crisis, we're now equipped as a system to figure out what resources are in your local community. There's so many toolkits out there. There's so many, literally, you can just Google, get onto your county or your John Muir and healthcare websites to look out and research. So that's a long-winded way for me to say that when you hear it, when you see it, more than ever, because it has taken a person that much longer, probably because not getting those milestones to practice reaching out to people, you should really take it seriously and support them in it. To answer your question, there is no one size fits all because, as I said, for one child or youth or family, it could be sport group. For some folks, it could be counseling, it could be therapy, it could be medications. It may be that you get your behavioral health needs met through a primary facility. So many of us, including our county, and Jesse, that's why we have relationships, because it should be, and that's some of the things that we're working on, no wrong door. There actually is no wrong way to ask for help. And there's some really good strategies. And even though you didn't ask this, if I can backtrack a couple of seconds, because another diamond that Jesse said was just the intersection with the workforce. As you can imagine, as he was saying, the actual people who are, I love all things sci-fi, so my mind pictures shields and magical swords and things coming out like the Super Friends, although I'm dating myself, or the Justice League, I should say, to help fight this crisis. What was interesting and what we found was, if you look at our healthcare partners, non-behavioral healthcare partners, there were, I'm being euphemistic, but now that the pandemic is over, what you will see is that kind of as that ripple returning is that people are now more frustrated. There's so much need. Where are our providers? Why is there not enough people? We're seeing the homeless crisis get worse, and you're seeing that exacerbated with people who have both behavioral health and homelessness needs. And it is unfortunately gone back a little bit to it being a blight, or how can you fix people who are suffering? And I just hope, because that's a difficult place to be in if you're a provider of mental health, behavioral health, you don't get any roses, but it's one of the hardest jobs to do, to actually work with a person who you can't visually see something to extract surgically. It is something over time. People have to be ready and engaged, and there'll be multiple, quote, failures before a person really is on the road to recovery. And so really helping and supporting those that are providing the work, giving them their due, because it really is an incredibly complicated state we're at. People are, again, much more in need. And I just hope that for those that are leaders or legislator powers that be can help reframe the conversation as to, we're not going to solve fill in the blank X crisis. We need more resources. Super Friends come together again, unite, that those workers that are struggling with the pay, who have a noble calling, really also need to be supported because they are really making a difference and have. So and that I think added a little bit to, at least for us, retaining people in the field. They really are just tired and had hoped, I think, like soldiers coming from a war, to be celebrated for their effort, just affirmation. And we're not seeing as much as that as we would like to see. So if there's a way to solve that quote, or at least lean into it, I think it would also make a huge difference.
I appreciate what Dr. Tribble said. And I think when we talk about workforce and some of the challenges in delivering care, we could have a whole other podcast on that, because there are unique challenges and there are clear things that we could do to improve that workforce. What really resonated with me is, what can we do to support our children and adolescents, or our brothers and our sisters, our grandparents, is that no wrong door approach, right? You see something, you say something, but in that no wrong door approach, you have to remove your judgment. And when you see something and you say something, you need to do it free of judgment, because if somebody is coming up and they have their worries, anxieties, and fear, and they took the stigma from the media or heard something, this is a diagnosis of depression, this is a diagnosis of schizophrenia, the diagnosis of bipolar, diagnosis of alcoholism, that diagnosis carries so much social weight in our society that people may be afraid to acknowledge that or move forward. And then that keeps them into their behaviors. All right. That may not be supporting health. When we have those conversations, especially initially, if it's a teacher, if it's a neighbor, if it's the mailman, if it's your barber or your hairdresser, having those conversations, see something, say something, and engage people non-judgmentally, so there's no wrong door approach. And no wrong door approach isn't related just to healthcare. It's related to society, right? Because as you mentioned, Jared, you were coaching your daughter how to order ice cream, right? No wrong door approach at the ice cream parlor. We are all in this together. And I think what Dr. Tribble was talking about, it's just not the behavioral health providers. It is us as society coming together so that we're supporting our children and adolescents so they can be full citizens. And if they have a diagnosis, physical or psychiatric or behavioral health, we're giving them the right treatment so that they can get over it and go back to living a life. And we're not letting that diagnosis define who they are. And we're not letting society put on those worries, anxieties, and fear that you'll no longer be a brother, you'll no longer be a sister if you have that diagnosis. I really like what Dr. Tribble said about the legislators and government. We want a no wrong door approach. And we need to make sure our behavioral health workforce is supported and we have the reimbursement so that we can bring more outstanding people into the workforce so that we can make sure we can provide early intervention and treatment. One of the things that we saw in the United States, a new study just got put out last year. I used to say when a child had a diagnosis of mental health, it used to take 5 to 6 years to get the initial treatment. Now it's up to 8 to 9 years. And that goes back to some of the workforce shortages, but also goes to the stigma of mental health, because people may be afraid to get their child into treatment to see a professional. Many times we rely on our school system. The more that we can get workforce, and we want workforce people with lived experience, oftentimes years, but we also need workforces of psychologists, of social workers, of physicians, psychiatrists, of nurses, of recreational therapists, everybody in the workforce, and especially those who have those professional degrees to provide evidence-based treatment. That's part of a team where we have lived experience, because we know when we provide evidence-based treatment and an evidence-based healthcare delivery, people get better. And the sooner that we can provide that treatment to individuals, the sooner we can eliminate the needless suffering. And that's what we want to have people do. Eliminate suffering. Build a life full of living joy. As Dr. Tribble said, sometimes when you experience joy, you got to experience some lows, especially when you're adolescents going through those relationships. But that's what we want people to be able to embrace. And we have the science to provide that. We now need the workforce and the economic engines to deliver that treatment to people with a diagnosis of mental health or substance abuse. And if we tell what we could do, no wrong door, see something, say something, and do it non-judgmental. Because when it's non-judgmental, that person's more likely to seek treatment and then give them the treatment. When people are judging what that person's going through, it's like a boomerang. The person who made the judgment may feel really good because they threw that boomerang back, but when it comes back to hit everybody. We want to stop that boomerang effect, stigma and discrimination with the mental health and substance abuse.
We can continue on, but I promised our guests that I would let them get back to their important days here. I may do something that I haven't done before and invite the same two to come back and continue this conversation, because we haven't dove into some of these innovative programs that both of them are working with. We haven't dove into the role social media is playing in mental health, and those are all key topics. What if people are looking for help in this? I know you gave some ideas, but is it 988? What do you want somebody to leave with? Where do they get help today?
Good question. I think for me, there have been so many kernels, so I hope whomever sees this, anything that resonated, I hope it was written down to think of. I would say first, as Jesse mentioned, see something, say something. But I want to back up a second. Recognize that the signs may be much more subtle than you imagine. And again, the stigma is showing us, unfortunately, that people are way over there. They're not like us. They're not me. They're not that, but they really are. Are you drinking more coffee these days? Are you sleeping more? Are you eating in a different way? Are you even exercising way more than you did? Your muscle mass is really off the chart. Those may be signs that there's something going on for you. And say it out loud. It's not a bad thing that you, as a human, a whole person, are going through something, because collectively we all are. Just facts. And so the ability to articulate that without judgment, as Jesse mentioned, or without stigma is critical. Recognize it. Are you out there like me? I'll plant trees. You see in my backyard. My kids are like, did you just plant another tree? Or did you get another goldfish for the pond? Yes. Whatever that is, it can be something as benign as that or more serious. But if you learn to say something and you give permission to people around you, first step. Then you identify what's comfortable for you, not only in terms of resources, access, yes, 988, church, hospital, your primary care physician, your nurse, your job. If you're employed, EAP is a fantastic confidential resource that you can call. You just look up those numbers. Telehealth. If you don't have resources, there are resources for those who have underinsurance or uninsured. I would literally, in the age of technology, I don't want to market a particular platform, but you can look it up on your phone. You can go to your local website. So there's so much out there, or you can just talk to someone that you trust, teacher, pastor, rabbi, folks in your community. It's just a way to access the service. So I'll stop there.
To follow up on Dr. Tribble and those excellent recommendations, starting with people that you trust, they're part of your community, they're part of people who you talk with daily. And if they're able to see something, say something, engage you non-judgmentally, that connection can have a huge protective factor. Then if you need to reach out to somebody, that 988, that warm line that California has, and it's across the country, that anybody can call 24 hours a day, 7 days a week to talk to somebody. And on that 988, those individuals are trained. They will get you to a local provider in your network if you need more care. Also, if it's a very acute situation, always go to your local emergency room. If it's life or death, or you're concerned if it's life or death, that's what local emergency rooms are here for. If it's physical, psychiatric, behavioral health, or substance abuse, 24 hours a day, 7 days a week. I know Motel 6 says they keep the lights on, but those emergency rooms keep the lights on, even during COVID, right? We're here to support people to get their recovery. We're also here to support people in some of the most challenging and frightening times of their life as healthcare providers. And we want to be there with them to help them get that care. I think the key thing is once they're in care, our systems of care can support them, and as a primary care is able to refer them to specialists that they needed, telehealth, in person. But the first thing that we can do is help to decrease the stigma of mental health treatment. Treat people not as their diagnosis, as people, use people first language. And by that, not think this person's bipolar, this person's cancer, this person has a diagnosis of bipolar, this person has a diagnosis of cancer. So it starts locally before we can change it globally. And those are some very simple things that start overcoming that stigma of mental health so that people do not feel judged. And when somebody sees something, they say something, and it's going to have those connections with your trusted friends. And those are some of the best protective factors and social determinants of health that we can build. Some, if it's a child, an adolescent, an adult, an older adult, those are the things that we know that have much more impact than people are aware of. And they don't cost a lot of money, but people have to change how they see one another with an open mindset, a humble mindset, and remove the judgment when they engage.
Such an important message and such an important topic, and more to come on this. Dr. Tribble from Alameda County Behavioral Health and Jesse Tamplen from John Muir. Thank you both for being here. I really appreciate it.
Thank you for the opportunity.
Thank you so much. It's always a pleasure to learn from Dr. Tribble and all the great work that she's leading.
Wonderful to be a partner.
Wait, don't leave yet. Hit subscribe. Make sure you get the weekly updates. We have a new episode every Wednesday for stuff happening in the East Bay. In the meantime, follow me on LinkedIn, Jared Asch, or check out our firm where we have a weekly newsletter and blog at Capstone Government Affairs on LinkedIn. Thanks for joining us today on the Capstone Conversation.